Real pleasure to be here. I only have 10 minutes, so I'm going to model what it looks like to have pressured speech. So I'd like to describe, well, I'm kind of learning on the job what a learning health network is. We have developed, I guess, what is a learning health network, a collaborative treatment network. And let me give you a little history about this. I'm interested in childhood onset bipolar disorder in two forms. First, kids that get bipolar disorder, bipolar 1 or bipolar 2, and actually have full manic and depressive episodes before they turn 18. And there's another group, which is a group of at-risk individuals who are showing early warning signs. That's where we have, I think, quite a bit of leverage to try to change the course of the illness if we can get in early enough before the full disorder starts. This started actually at a meeting. I was talking with my colleague Bob Post, who I think some of you know, Robert Post, and he and I were both talking about the fact that there are a lot of people around the world studying bipolar disorder in children. None of us diagnose it the same way. There isn't even national country to country or even parts of the country agreement about how to diagnose it. We really need to have a network that shows what the standards are for diagnosing, following, and treating these childhood onset disorders. So let me get more specific. We have a couple of assumptions here. One is that collaborative networks can address larger scale questions about the best treatments for kids with the bipolar disorders or at-risk conditions. But in order to do these large-scale trials, we need to first show that a network can diagnose, follow, use the same treatment protocols, and hopefully get similar outcomes on similar kinds of patients. Third, because we're studying kids, a lot can be learned from smartphones. Most of them are on their smartphones 24/7 anyway. Why not figure out a way to track moods, give health advice, and so on using smartphones? This is a little bit about pediatric onset bipolar disorder. I won't belabor you with the details, but we know that it's highly comorbid with other conditions such as anxiety, ADHD, oppositional defiant disorders. The earlier the onset, the worse the outcome, unless you can actually get in and treat very early on. We also know that it really runs in families. You can see multiple generations with either the full disorder or sub-threshold versions of the disorder. But what about this category we're calling high risk? What do they look like? Well, really we're talking about kids who have sub-threshold versions of bipolar disorder, but at age 9, 10, 11, 12 years old. A couple of criteria. First, they have to have a family history. They have to have a parent, usually, who has either bipolar 1 or 2. We want to see some evidence of recurrent hypomanias or depressions that are subthreshold. They don't last as long as a typical DSM-type mania. They might only last a day or two. We want to see a change from baseline functioning. When people talk about hypomania, there has to be observable change. Or we at least need to see a major depressive episode in a kid who has a family history of bipolar disorder. For those of you who treat kids, you know that you don't treat a child with depression and a family history of bipolar disorder the same way you would a kid with just major depression, because you have to be very careful about antidepressants and setting off cycling patterns. Why is this important to look at high-risk kids? Because if you take a cohort of kids at risk, they have about a 50% chance of developing the full illness within 5 years. That's been well established in longitudinal studies. So this is a high-risk population. We want to be able to understand that at both a biological and a psychosocial level. Now, if you follow these kids over time, yes, about 50% develop full bipolar 1 disorder, but what's in some ways more interesting is to look at trajectories over time of how much time do they spend symptomatic versus how much time do they spend in euthymic phases. We were able to identify 3 subgroups in a sample of 126 kids. One group was this red line here, where kids basically were chronically ill for about 3 or 4 years, either with depression, hypomania, mixed episodes, never really got better. The The second group is the blue lines here. These are also chronically ill, but at a more modest level, so they were able to function for the most part. But then there's this third group that seems to recover over time, that if you follow them up into late adolescence or early adulthood, they seem to be better. And that is part of our journey here, is trying to understand who those kids are and why some of them seem to be over bipolar disorder by the time they're in their late teens, early 20s. Maybe it's a little bit like antisocial personality, where you can have a time-limited adolescent form that seems to clear by adulthood. We don't know. This is a brief summary of our design. As you can see here, we're just starting off small. We have 4 sites. We have about 15 to 20 kids we're going to see per site. We're going to do what's been called here deep phenotyping, a full diagnostic battery. We're going to measure mood instability. Mood instability is a behavioral marker of bipolar disorder. Simply put, it is kids who change moods a lot, but not necessarily in terms of manias and depressions. What their parents describe is outbursts of irritability, anxiety, crying suddenly, laughing suddenly, getting too close to people that they barely know. This sort of up and down movement of moods is, for some kids, a trait marker that you'll see even in between episodes. And we know that's important because it's also a prognostic indicator of who's going to do worse over time. One of the ways to do that is with what we call the ecological momentary assessment method, which is a fancy way of saying you ping them on their smartphones every 4 hours, every 3 hours, ask them about their moods, and you start seeing this kind of up and down movement. Here's an example of one such kid who we called subthreshold bipolar disorder. The top line is ratings of hypomania and depression. You can see over a 3-week period, there was quite a bit of up and down movement in this kid. In the third row down, he's also rating family stress. There's quite a bit of family stress during the same interval. If you can get kids to do this, and that's a big if actually, is to get them to stick with this kind of protocol, you can learn a lot about their course of illness and what medications are working, what psychotherapies are working, and so forth. Over time, we're going to follow kids over a 12-month period, so we'll measure mood instability. We have one biomarker we're looking at, C-reactive protein, which has been found to be important in adolescent bipolar disorder, and then we'll follow them over a year. But the key here is we want the sites to use the same battery, the same assessments, the same medication protocols, the same decision rules, so we can determine whether this is actually could become a learning health network. Here's an example of an algorithm that we've developed in our research for treating kids with major depression versus the subthreshold forms of bipolar disorder. I won't bore you with the details, but they involve different kinds of medications. So, for example, you might start with an antidepressant. If you've got just major depression, you might want to accompany it with a mood stabilizer if you're dealing with a kid who's showing early mania or a great deal of mood instability. So we have a centralized committee that's going to check all incoming cases and give advice really to the physician, not binding advice, but here are the medications you might consider, here are the change strategies you might consider using. We also are big in our network on psychosocial treatment. And let me make a plea for involving psychotherapy in any of these longitudinal studies. First, we know that psychotherapy and medication are synergistic in both depression and bipolar disorder, that kids and adults do better if you combine psychotherapy with an optimal medication regimen. That can be individual therapy, group, or family therapy, which is our particular specialty, where we work on communication within the family, conflict resolution, educating the family about what bipolar disorder is, how to recognize the early warning signs, and to take this a step further, let's imagine we were to study keto diets in an adolescent or a childhood sample. You're really going to need to have the family's buy-in to make that possible. There's got to be agreement in the family that this is a condition that needs to be treated, and one way to treat it is with diets. That otherwise, I don't think we can count on a 9 or a 10 or 12-year-old kid to follow a dietary plan. So that's one of the reasons we involve the family in these treatment protocols. In addition, we've found that if you combine family therapy with medication, or even without medication for these high-risk populations, you can stave off the onset of new depressive episodes. We did a randomized trial. Here are the results. Kids who got family therapy lasted longer, survived, as we call it statistically in the community, longer if they got family therapy than if they were followed with usual care, even if they got medications. And we've found this in 9 studies at this point of both adolescents and adults. It's a well-replicated finding. What are some of the directions we want to take? Because this network is set up to do randomized comparative trials, once we've shown that we have reliability and that we can diagnose the same way, then we're in a position to start comparing different agents, different psychotherapy agent combinations, keto diets, and acetylcysteine is one thing we've talked about. Mobile apps as adjunctive to medications, whether you get any additional bang for the buck by having a kid monitor their moods or the parents monitor their moods and stress factors. So I think once we have this in place with common ways of diagnosing, then we have more reliable data that we can then filter into the field. This is our team on a relatively good day in our natural habitat. We all live in these little boxes in Los Angeles. And I want to thank Jan and David Baszucki, Carolyn, Carl Altimus, and Andrew Chen, and the Milken Institute for inviting me. Thank you very much.